So thank you very much, everyone, for coming to this symposium organized by Ezisurg Medical. In these modern times, we are confronted by many technical advances that are sometimes very difficult to actually navigate, and sometimes even very difficult to work out what is the best technique for any one procedure, for example. And today we have two very distinguished surgeons, Professor Yves Panis from Paris and Professor Rudolf Ott from Berlin, who are going to try and help us navigate some of the literature and some of the difficulties around these many technical areas, and perhaps even how they can relate to long-term outcomes in both colorectal cancer and low rectal cancers as well. I think this is going to be a very exciting session because it takes something that we have a lot of noise about within the literature and within our colleagues as well, to try and bring it all together to see how we can make technology our friend to bring out the best in these patients who need us the most. So I'm going to start off with introducing or inviting Professor Yves Panis from Paris to give us a talk on the new paradigms in low rectal cancer management. Over to you, Yves. Thank you.
Thank you, Janindra, for your kind introduction. So the aim of this presentation is to try to answer some new questions in low rectal cancer patients. First, about neoadjuvant treatments, because we know that new randomized studies were published very recently. So second is the best technique for total mesorectal excision, open laparoscopy, TIA-TME robots. And the last question is, what is exactly the place for organ preservation in patients with low rectal cancer? So first, a big question is neoadjuvant treatment. You know that for many years, in patients with T3, T4 node positive cancer, we discussed to do neoadjuvant long course radiochemotherapy before surgery. Was published very recently two big randomized trials. This one is a Prodige 23, which is probably the biggest from France, was published about the idea to give a longer neoadjuvant treatment, starting with 3 months of FOLFIRINOX, then radiochemotherapy, then surgery. And for the first time, this paper, this randomized study, demonstrated two very important results. First, that the disease-free survival at 5 years was significantly improved by the new protocol. And the second thing is that the pathologic complex response rate was 12% in the standard group and 28%, which is very high, in the new treatment. So maybe is it the new standards for low and mid rectal cancer, T3 and T4. And exactly at the same time was published in UK the Rapido trial, which observed exactly the same result, I mean, higher rate of complex tumor response, exactly the same number, 14%, 28%, and exactly the same long-term results, benefit in long-term survival, in disease-free survival, but no benefits in terms of overall survival. So after these two studies, Prodige 23 and Rapido trial, we can say that today, maybe the new paradigm for neoadjuvant treatment is to give a long neoadjuvant treatment with chemotherapy and radiochemotherapy. To say that Prodige is better than Rapido or the opposite, we don't know, but to give only in fit patient, only the standard long course radiotherapy, maybe it's not enough anymore. The second thing is how long to wait after neoadjuvant treatment. For many years, and you have on the left of this slide, the first randomized study from France, which seems to demonstrate that if you wait 7 weeks after the 5 weeks radiochemotherapy or 11 weeks, it's exactly the same. In fact, it's not true, because since this publication, 3 or 4 randomized studies have clearly demonstrated, like on the right of this slide, that if you wait 10 weeks or more after the end of radiochemotherapy, you increase the complete response rates. So today, for many authors, it's better to wait 10 to 12 weeks to do the TME after the end of radiochemotherapy. And if you discuss, we will discuss later, if you discuss about organ preservation, there is no protocol where you discuss organ preservation after 6 weeks. You need to wait longer. And which is interesting is this meta-analysis published in British Journal of Surgery 2 years ago, which clearly demonstrates on the bottom of the slide that the morbidity rate is exactly the same between a short delay after radiochemotherapy or longer delay. For many years, some surgeons say, no, it's not good to wait 10 or 12 weeks because morbidity is increased. It's not true. And which is also interesting on the top of the slide is that the long-term survival is maybe better, recurrence-free survival. So for all these arguments, we need to wait more than 8 weeks after the end of radiochemotherapy. After this, we will do the total mesorectal excision. What we know today, because of the benefit in the postoperative result, lower mortality, lower morbidity, in the long term, exactly the same long-term result between open and laparoscopy. Here is the example of the Color 2 study. We need to do this operation by laparoscopy because it's better than open surgery. But there is some alternatives. The first alternative is the robotic surgery. Here is the first randomized study, the ROLAR trial, with exactly no difference between laparoscopy group and robotic group. The primary endpoint was conversion rate, no difference. And I put on the bottom of the slide all the important criteria, morbidity, mortality, no difference between the two groups. And which is interesting is this recent meta-analysis published in colorectal disease, which clearly demonstrates that whatever the criteria you choose, especially in randomized study, no benefit of the robotic approach. It is exactly the conclusion of this meta-analysis. Sometimes in non-randomized study, it seems that you have a lower conversion rate, for example, but if you make a subgroup analysis of the randomized study, no benefit even in the conversion rate. So today, we have no evidence that robotic is better than the functional result at 1 year, exactly the same. So for us, at least for us, a new paradigm in 2021 is that for mid-rectal cancer, we do stappled colorectal, always end-to-end anastomosis with a temporary stoma. But for low rectal cancer, instead of a classic side-to-end manual coloanastomosis, we do a delayed pull-through manual coloanal anastomosis without temporary stoma. And we observe a very low rate of leak with no complication because no of stoma. Last question is a suspicion of complete tumor response after radiochemotherapy. You know that it's observed up to 25% of the patients. We have, beside TME, which is a standard, we have two options, watch and wait or local excision. No randomized study on watch and wait. Just I show you one of the biggest study from New York, which is an expert center in watch and wait strategy. And they compare patients after TME with complete response and 113 patients with suspicion of clinical complete response managed by watch and wait. They observe among 113, 22 local regrowth, and all the papers say that the local regrowth rate is at 3 years up to 30%. So we need to follow the patient. And it's not my conclusion, it's the conclusion of the guys from New York, is that if you have a local regrowth, the long-term survival is maybe worse than if you do a TME. So today, to say that there is no risk with watch and wait is not true. So we need to, maybe it's the best, it's a good technique, but we need probably more evidence. The alternative is to do a local excision, like on this slide. Just to remind you that after neoadjuvant radiochemotherapy, what is a good indication, this review clearly shows that the local recurrence rate is up to 25% if it's a YPT2. So the conclusion is that you need to do a salvage TME if it's YPT2 or YPT3, even if you are R0. And if you are YPT0 or T1, you have 4% or 12%. It's the guideline. you can follow a patient if it's only YPT1. And there is only one big randomized study from Eric Rullier, which was unfortunately negative. And the reason why it was negative is that the primary outcome was a composite score, no difference between local excision and TME because of the high morbidity rates of patients undergoing local excision and then salvage TME because of the intent to treat analysis. So today, in conclusion, we can say that there is a new paradigm for neoadjuvant treatments, which calls the TNT, total neoadjuvant treatments. According to PRODIGE 23, it's 3 months of FOLFIRINOX, followed by radiochemotherapy, followed by surgery. Concerning the alternative is to follow by rapido with short course and chemotherapy. TME must be delayed around 10-12 weeks in order to have the highest complete tumor response rates. We need to do by laparoscopy. It's today the rule. No benefit of robotic approach and TI-TME, bad result in Norway. Concerning the way to do the anastomosis, you can do the standard manual side-to-end coloanal anastomosis with temporary stoma. I propose to you a new paradigm, maybe because lower leak rates and no stoma, it's to do a delayed pull-through coloanal anastomosis, but probably we need more evidence. If you have a suspicion of clinical complete response, rectal preservation is not validated. Maybe we need more study, more randomized study. You have two options, watch and wait and local excision. And maybe if you are not a big expert, maybe you can start by the most difficult case, selected cases, age patient, indication of IPR, and not to do in all the patients because the risk is that you have not a complete response that you need to do a salvage, a TME, which increase the morbidity. Thank you very much.
Thank you very much, Yves. That was an excellent overview of how the paradigms are probably changing in rectal cancer, as well as how we look at things. And I think we'll go to some very good discussion after Professor Rudolf Ott talks to us today about technical skills and how they may affect the long-term outcomes in colorectal cancer. Thank you.
Okay, thanks for the kind invitation. In colorectal cancer, many prognostic factors which are determined by the tumor and the patient are well defined. The surgeon is regarded as a prognostic factor too, but the real impact has not been widely recognized. So in 1998, an important paper on this issue was published from Canada. They analyzed a series of nearly 700 potentially curative rectal cancer resections with there's almost complete follow-up. And they found that only surgeons who had undergone a specific colorectal training after their general fellowship and who did have experience of more than 20 resections had good results. If patients were operated by surgeons who were not trained and had no experience, there was a very high rate of permanent stoma, an acceptable high rate of local occurrences up to 40%, and a very poor overall outcome. So in the 1990s in Sweden, there started trials to analyze preoperative radiotherapy for rectal cancer. And as one side effect, they found a significant variation in local recurrences between the participating surgeons. After that, they started a TME project to train all surgeons in the total mesorectal excision that was promoted at that time at HEALD. And this TME project included various video sessions and workshops. And after completing this TME project, they observed a drop in the rate of permanent stomas from almost 60% to 30%. The local occurrence rate was less than half, and also the distant metastasis dropped down, and the disease-free survival improved by 12%. So that were real impressive results by just training surgeons. Similar results came from a Netherlands TME project, and they had pretty much the same results, less than half of local occurrences after training of surgeons, and a 10% survival improvement after 2 years. This concept of total meso-excision was adopted by others to the colon cancer. In my previous home university in Erlangen, it was introduced the concept of complete mesocolic excision. And this includes the complete preservation of the mesocolon with a real central ligation of the vessels and a real central lymph node harvesting. In a Danish study, which was published in 2002, there was an improvement of 10% in the early tumor stages by adopting the CME compared to staying with a conventional approach. So all these results were gained, were based on open surgery. But in the meanwhile, laparoscopic surgery has evolved rapidly due to its known benefits: less scars, less pain, faster recovery. And in the beginning, there were concerns that laparoscopic surgery should not be applied in cancer surgery as well. But in the meanwhile, there are a lot of studies comparing open and laparoscopic, or even robotic technique. And our evidence is today that laparoscopic surgery is at least comparable to open surgery in terms of safety and outcome. So nowadays, in Western countries, nearly 50% of all colorectal cancers are resected in laparoscopic technique. But laparoscopic colorectal surgery is quite different from open surgery in terms of tissue handling, exposure of dissection planes, handling of unexpected problems, and doing anastomosis. So very different technical skills are required and have to be learned by surgeons. So this is a case of a T1 sigmoid carcinoma, which was initially endoscopically removed and turned out to be a high-risk cancer. And as you see, the mesocolic fascia can easily be exposed. You can preserve the autonomous nerves very easily, and you can dissect the inferior mesenteric artery at the origin of the aorta. So you would agree that's real an easy case, and probably you need just a standard surgical kills to perform that. We dissect the artery, we don't expose it to the artery at the aorta, and can easily follow the embryonic planes. We dissect the colon distally with these angulated staplers. This is very important if you do a very low resection, and this is done as standard stempling of the of the anastomosis, and this is how we handle dog ears, which are a risk factor for anastomotic leakage. So we routinely perform ICG fluoroscopy in rectal cancer, sometimes also in colorectal cancer. But it's not always that easy. Then in this early case, if patients are obese, if you have previous surgery, this can colorectal surgery much more demanding. In my experience, it's easy to do it left colon resection, but it's different from the right colon, where it's probably demanding to dissect the vessels at the pancreatic head without injury to manage bleedings. And as you've seen in the presentation of Professor Panis, especially low and middle rectum cancers are specifically demanding to the surgeons. So in many countries, there are efforts to train the endoscopic skills of the surgeons. And recently it was published a paper from Japan, and they found that surgeons who underwent such a training program had shorter operative time and less perioperative morbidity. However, they could not demonstrate a benefit in long-term survival. So that does not contradict the need for such training systems, because we've learned from open surgery, it's the combination of training and experience that brings good results. So to my knowledge, the first study trying to correlate individual skills of surgeons with outcome came from an Australian group. They used data and videos from 2 laparoscopic rectal cancer trials in laparoscopy. And these videos were independently analyzed, blinded, using a specific performance tool. This was very time consuming, and they built skill scores. And they found that high-rated skills showed a trend toward local recurrences and a trend toward longer disease survival, but there was no significant differences. So probably this can be explained, the non-statistical difference, that the most of these surgeons participating in the trials were already experienced and trained in laparoscopic rectal surgery. But striking results were presented from another study from the United States. Here, 15 surgeons submitted a video of laparoscopic right hemicolectomy done in 2016. And these videos were again independently reviewed by 12 surgeons. And using a specific assessment tool of the American Society of Colon Rectal Surgeons, a skill score was built. And the outcome of the individual surgeons were retrieved from the National Cancer Database over a 6-year period. And what they found was that the high-skilled surgeons performed significantly more operations than the low-skilled surgeons, and the outcome was far better. And the difference between the high-skilled and the low-skilled surgeon were 20%, and that's a big thing in oncology. So in summary, I think the technical skills of surgeons in colorectal cancer, they do affect long-term survival and indeed quality of life. The requirements on the technical skills of surgeon depend on the location, the extent of the tumor, and indeed on the patient. The learning curve in laparoscopic surgery is probably longer than in open surgery, and the technical skills of surgeons have to be trained, evaluated individual colorectal cancer surgeon. I think they have to be made transparent. Thank you for your attention.
Thank you very much again for what was an excellent presentation and overview on technical skills and how they would also impact on our day-to-day life as a surgeon, or our day-to-day life as patients, really. If you stop sharing your screen, we can then go into a discussion for the next 10 minutes or so about on some of these aspects to bring it all together. So I think I was going to start off with you, Eve, which is you brought some very important points and very new data on neoadjuvant therapy, because the pendulum for neoadjuvant therapy seems to swing this way and that way, depending on A, who you talk to, and B, where you work. And I was very interested to see that maybe the pendulum swinging back towards more neoadjuvant treatment, or for our patients having more neoadjuvant treatment. And I think part of that might also be related to the trend coming in with, for watch and wait, or looking for a pathological response at least. So I'd like a little bit more of your thoughts on how you might see whether we'll see complications after surgery, because we also know that neoadjuvant treatment, in particular radiotherapy, gives you a lot of long-term complications. So are we going to see the pendulum swing from the functional point of view as well?
So I agree with you that morbidity, function, quality of life are important factors. But today, if we speak about rectal cancer, the oncologic results is the first factor. And what we observe with this 2 randomized study is that for the first time, we observe a 28% of complete response and better disease-free survival. So today, if you discuss a neoadjuvant treatment in a fit patient, young patient without comorbidity or major comorbidity, and a T3 or T4 nodes positive low and mid rectal cancer, if you say, okay, forgot these 2 recent studies, we will do long course radiochemotherapy with capecitabine, maybe there is a loss of chance. And today for us, in the MDT, we discuss PRODIGE 23 for all the patients fit for this protocol. I know that this protocol is very hard, is longer, but which is interesting is that there is no difference in morbidity, and which is very interesting is that if you give adjuvant chemotherapy after surgery, the side effect of the chemotherapy is lower in the patient who received before surgery chemotherapy. So today, for us, we continue to do standard long course radiochemotherapy for 5 weeks in old patients, in T2 nodes positive, in small T3. But if it's a young patient, less than 65, with big tumor, we do PRODIGE 23.
Gotcha.
It's for us, it's a new standard. And the only alternative is the Rapido trial in UK. But in France, we don't use a lot 5 days radiochemotherapy. We prefer long course. We don't do short course because it's difficult to organize for the logistic. But it's exactly the same results, so you can choose. But to say today in 2021 or even in 22.
And to finish off, Rudolf, your approach to the dog years, because I find that is also one of the big issues, especially in the double staple, which is why I moved, especially in the pouch surgery, to doing double purse string, and I found that makes a big difference. And I know there are new staplers coming about to try and avoid the dog years, but I find that does cause a lot of problems. So I was curious to see how you avoided all of that. I know you briefly showed it in the video, but a little bit of elaboration.
Well, I just pulled the dog ear over the distal of the stapler. So as far as I know, the Barcelona group is starting a trial suturing these dog ears to the distal of the stapler, the controlled trial. I don't know whether they have just started to recruit patients, but I think that's a big deal. So I've learned rectal surgery and open surgery always a double purse string technique, and that proved to be very safe.
Yeah, good. Thank you. Well, I think we've run out of time for discussion. So I want to thank you both for fantastic presentations and some really insightful new ways of thinking about things, and also for us to bring together not just all of the technical aspects, but how we as individuals can affect the outcomes of these patients in our decision making, and also following these technical aspects. So I hope this has been a very useful presentation for everyone listening. Thank you both. And thank you.
Thank you for moderation. Thank you.
Thank you.
Thank you.
Bye.